Management of shock. Learning objective. By the end of this video, the participants will be able to acquire skills to diagnose and provide initial management of shock. Skills for starting IV line, maintaining airway, oxygenation and bladder catheterization will also be explained.
स्टाफ पेशंट खूप सिरियस आहे 3 तासापूर्वी डिलिव्हरी झाली रक्तस्राव खूप होतो
होय बर मी तपासते
A woman has come after delivery with the complaints of excessive bleeding. She has to be assessed quickly and initial management has to be given. Rapid initial assessment for circulation, airway and breathing shall be done by examining her.
पेशंट खूपच सिरियस आहे मामा लवकर डॉक्टरांना बोलवा
Blood samples are taken for hemoglobin, grouping and cross-matching, blood urea and serum creatine.
मावशी हे सॅम्पल लगेच क्रॉस मॅचिंगला पाठवून द्या
Crystalloids, Ringer lactate or normal saline is initiated. The first drip should be fast and timed for approximately 1 liter in 20 minutes. Estimated replacement is usually 3 times the blood loss. If the drip is given very fast, remember to check vitals and lung bases to rule out pulmonary edema. Position the woman on her left side with her legs higher than her chest. Keep the woman warm. Remove any obvious obstruction from mouth for a clear airway. Give supplementary oxygen. Blood should be warmed by holding it against your own body. Catheterization should be done for monitoring urine output. Steps for catheterization. Check for items needed for catheterization. Sterile or HLD gloves. Indwelling catheter of appropriate size. 10 cc syringe with needle. Normal saline or distilled water for balloon inflation. Kidney tray. Antiseptic solution, Eurobag, sticking tape, light source. After routine hand wash, put on sterile gloves. Clean the vulva with wet cotton swabs soaked in antiseptic solution. Use one hand to gently separate the labia. Use the other hand to cleanse the labia and urethral opening with swabs soaked in antiseptic solution top to down direction. Place the kidney tray in between the woman's legs, close to the perineum. Assistant opens the sterile catheter back and the nurse takes it out. Ensure the distal end of the catheter is placed in the kidney tray while inserting. Use one hand to gently separate the labia from above and with the other hand insert the tip of the catheter into the urethral opening. Inflate the bulb of catheter with 10 ml normal saline. Connect the other end of the catheter to the uro bag. Check the flow of urine. Secure the catheter with sticking tape. Maintain and monitor the intake-output chart. Keep monitoring the vitals, that is, pulse, blood pressure, respiratory rate to check progress in the condition of the patient. Before administering more IV fluids, reassessment needs to be done as per the table given below. Signs: estimated circulating volume lost, fluid replacement, no symptoms or signs, up to 500 ml equal to 1 IV bottle, increase in pulse and respiratory rate, cold and pale skin, 1.5 liters equal to 3 bottles, increase in pulse and respiratory rate. Only now fall in BP. It is a late sign. Cold, clammy skin, agitated response. 2 liters equal to 4 bottles. Cold and clammy skin. Confused, agitated and aggressive behavior. Rapid pulse and respiratory rate. BP is falling and bleeding continues. Over 2 liters. More than 4 bottles. The blood loss is replaced by IV fluid. IV fluids should normally be given when losses amount to 700 ml. That is 15% of circulating blood volume. The initial replacement should be about 1 liter in 20 minutes, and further fluid requirement will be calculated by the existing situation as monitored from the vitals. If the estimated blood loss is more than 2 liters, blood transfusion may also be required. Note: even mild blood loss can sometimes be serious for the patient in case the hemoglobin is low. Don't give oral fluid. IV colloids. Example: Himaxal. Pillow under head. Part 2. Case Scenario 2. Sometimes you may come across a situation when the woman is unconscious and she is in shock. Take additional steps such as position the woman on her left side with her legs higher than her chest. Circulation. Maintain circulation as explained earlier. Airway and breathing. Remove any obvious obstruction from mouth. Do suction if needed. Perform head tilt by placing hand on patient's forehead and tilting the head back. Perform chin lift by placing 2 fingers under the patient's chin and lifting the chin forward. Jaw thrust performed by placing fingers behind the patient's jaw and lifting the jaw forward. Insert airway adjunct. Example: oropharyngeal airway to keep airway patent. Assess breathing for 10 seconds. Look for chest movements. Listen for breath sounds. Feel for air movement. Note: If there is absence of breathing in an open airway, take this as an absence of circulation. If the patient is not breathing, give 30 chest compressions followed by 2 breaths. Chest compressions are delivered to the middle of the lower half of the sternum. Place the heel of your first hand on top of the other and interlock the fingers of both hands. Keep in midline to ensure that pressure is not applied over the ribs. Do not apply pressure over the abdomen or bottom tip of the sternum. Lean well over the woman and with your arms straight, press down vertically on the sternum to depress it approximately 4 to 5 centimeters at a rate of 100 compressions per minute. Change the person delivering the compressions every 2 minutes, but avoid delays in changeover. Breaths are delivered by a face mask and self-inflating bag or pocket mask may be used. Maintain head tilt and chin lift when giving breaths. Each breath should last about 1 second and should make the chest rise, as with a normal breath. Reassess the woman's response to IV fluids within 30 minutes for signs of improvement. Monitor the pulse, blood pressure every 15 minutes. Note urine output and watch for puffiness. Once the initial management of shock has been established, a detailed history and examination is to be done by the treating doctor and/or specialists. The cause of shock is established and treatment is given as per the cause. In case it is PPH, as the present case scenario indicates, then give injection oxytocin, other drugs and other interventions as per the protocols for management of PPH. Always initiate the management as per the resources available at your facility before referral. Along with the management of the patient, also ensure the availability of referral transport, and the patient should be accompanied by a medical help with continuous life support measures. Inform the facility being referred to about the condition of the patient being referred. One of the medical assistants should explain the patient's situation to the family members and should complete necessary documents before referral. All service providers, either A&M or staff nurse or a doctor, must undertake the following critical steps even in scarce resource settings. Maintain circulation, airway and breathing. Must initiate IV line with rapid infusion. Give oxygen. Arrange the transport before referral. Key points. When you see a woman in shock, check her vital signs. Insert number 16 or 18 IV cannulae in 2 veins and infuse 1 liter of Ringer lactate solution rapidly in 20 minutes. Catheterize the urinary bladder and arrange for urgent referral to FRU. Maintaining circulation, airway and breathing and giving oxygen while referring the woman to well-equipped hospital are critical steps to be followed by all healthcare providers.